I am Keith Crawford. I'm the Director of Clinical Trials and Education at Finn. I bring you greetings from our president, founder, and 20-year survivor, Thomas Farrington. 2020 has been a very rough year for us. 191,000 new cases of prostate cancer are predicted. Of that, an additional 33,000 people, men with prostate cancer, are predicted to die. African-American men who are at high risk for prostate cancer, close to 30,000 new cases, of which almost 5,400 deaths from prostate cancer will occur. COVID hasn't stopped Finn's mission to educate men, African-American men, about prostate cancer. So all it did was accelerate our efforts to educate. So I'm pleased to welcome you to our Talk with Our Doctor series. Our speaker this evening, it's very important that you recognize we bring in doctors from around the country to talk about key topics. Dr. Simon Blanc, he's a hematologist, oncologist from Florida's Precision Oncology practice. He has extensive background in clinical trials. He was at MD Anderson, did training there. Memorial Sloan Kettering Cancer Institute, training there. Fellowship at Hematology Oncology in the University of Miami, Sylvester Comprehensive Cancer Center. Now he will talk to us about understanding ways, understanding the treatment challenges of prostate cancer. Now, as I said before, it's very important to recognize that we've moved towards virtual programming. Because we've moved towards virtual programming, we really want to thank our sponsors. Now, these are the people that make it possible for us to provide you the programming and this programming and many of the other activities that Finn is able to provide to you. Now, you'll see the sponsors on the screen. Now, these organizations help us provide you with the programming that we provide, that you see. And we want to thank them very much for allowing us to continue to bring you these programs. Now, I'd like to give you an idea of what you will experience or learn today. During this session, we will review something that's extremely exciting to us. It's FinnPath. We're this new launch of an educational tool by Finn. Now, FinnPath is for the patient, for the caregiver, for the loved ones, to help them better understand what the treatment options are and what exists. Now, we're moving towards shared decision-making. And what that means primarily is that the patient will have an opportunity to speak more proactively with his doctor and to get an understanding of what the potential treatment options exist for him. But remember, a clinician, a doctor, has had more than 20 years of experience in this medical space. And what is being asked is for the patient, the loved one, the caregivers to now race up to a point where they could hold an intelligent discussion and a rich discussion with the clinician. That's very difficult to do. But we feel with FinnPath that we have a tool that will assist the patient in doing so. Now, after I review the FinnPath educational tool, I'll bring in Simon Blanc, and he's going to talk to us about better understanding today's treatment challenges. Some of the areas that he's going to talk about is to really talk about prostate cancer as a continuum, early diagnosis to metastatic disease. And then he's going to give us definitions or a better understanding of what non-metastatic prostate cancer is versus metastatic castration-resistant prostate cancer. He'll also introduce us to a wide variety of clinical options, and then also give us some background and some biology about androgens, these testosterone um, hormones that men have, that and how they relate to prostate cancer. So we recognize that we have a tremendous opportunity for learning here, and we want you to ask questions. So if you post your questions, you can post them in the Zoom question and answer box. And for those of you on Facebook, we ask you to post your questions through Facebook. So now what I would like to do is make sure that I'm going to move toward the fight tool. And we're going to move toward FinPath first. And this is an easy to use tool. You have it on your computer, on your pad, or on your phone. Now, what we've done is try to simplify the particular options that a patient may have. If you look across the top, you'll see home, treatment pathways, information, and helpful hints. Also, some additional information if you want to get in contact with us or any other additional information. But I want to bring you to the treatment pathways, and I'm going to bring you down to treatment pathways. If we scroll down, the treatment pathways are broken up into 5 different sections here. Initial prostate cancer diagnosis, PSA recurrence after surgery, cancer progression after radiation treatment, hormone-sensitive cancer, and castration-resistant cancer. And so we simplified it into these particular boxes so that now a patient starts at a very high level and starts to move, can narrow down. Now, if we go to treatments, it'll bring us to another window, the initial prostate cancer diagnosis. Now, we don't want you to go any further. We want you to start at understanding the risk level. And again, making it as simple as possible, we want to show you what are the most important factors, things that you need to walk away with from your doctor so you can have a more intelligent, more shared decision-making process of your particular treatments. So your PSA, prostate-specific antigen, your biopsy results, your Gleason score, your grade or group, and your cancer stage. Once you have that information, then you have the ability to then understand what your risk level is. Now, is your risk level low? Is it intermediate or high? Is there regional involvement or is there metastatic involvement? Now, if we move back to the initial prostate cancer diagnosis, you can then click on a tab, arrow, and it will take you to additional information where you understand the life expectancy or your treatment options that exist. So if we go back to home, and if I come to the drop-down window, not only the initial diagnosis, we talked about recurrence, cancer progression. If you also need some information about what is a prostate, the average person doesn't know what a prostate cancer is and where it's located. So you can even find educational resources that will allow you comparisons between the walnut and the lemon, and the walnut being the normal size of a prostate cancer, understanding what the disease looks like, points, terms that you hear. How is the prostate cancer detected? What is a PSA test? All of this information is at your fingertips. So what I wanted to do is give you a scenario of a patient, 63-year-old African-American man. He's been monitored for PSA, for prostate cancer, for about 50 years. Now, he shows up in his doctor's office with a PSA of 21. Now, the doctor and the patient have already been discussing their, talking about prostate cancer as it relates to African-American men who are at high risk. So the patient is referred to a urologist. Urologist then collects additional information. They perform a biopsy. They recognize that majority or over half of the prostate had cancer involvement. Patient was given a Gleason score of 8. And then the bone scan or MRIs were negative, so there was no movement away from the prostate cancer. So that's the information that we have with this patient. So if we drop down under this initial diagnosis, we'll go to treatment. We'll go to understanding our risk level. And what did we learn? The gentleman had a PSA of 21, and the biopsy results were over 50% cancer, over 50% of the prostate. If we drop down and we start looking, and we'll see a patient, if I started intermediate, patient with an initial diagnosis that includes a Gleason of 7. Well, he doesn't have a Gleason of 7. If I drop down to intermediate again, they're still talking about 7. I said the gentleman had a Gleason score of 8. So now, under high risk, a Gleason score of 8, notice that the PSA was above 20. And I said earlier that his PSA was 21. So now this allows the patient to identify where their risk level is. And for this person, it looks as if he's a high-risk patient. So if we go back, drop down to high risk. We click on high risk. And it brings us to a category that gives us additional details. But you need to stop for a second, because what people will need to talk about is what is the life expectancy of the person. Now, because depending on how long it's anticipated for you to live will determine what the treatment options are. If you click on life expectancy, we'll use the Social Security Actuarial Life Table. This gives you an idea of how they anticipate how long a person will live at a particular age. So we're going to focus on these outside columns, exact age and life expectancy. And I said that this gentleman was 63. And if I scroll down, 63 years of age, his life expectancy is close to 20 years. So if that's the case, we scroll down a little further. Life expectancy of greater than 5 years, the type of treatments that are available to him are here. Radiation, and ADT, surgery, and even clinical trials are an option. And this is very interesting because a lot of people don't recognize that part of your treatment plan is the participation in clinical trials. So in this case, let's click on a clinical trial. Now, this will take us to our FIGHT tool. Now, this is something that we had created before to help better organize the information that's available when it comes to clinical trials for prostate cancer patients. Now, we've grouped our FIGHT tool into 6 different categories. And I'm just going to stop at high-risk prostate cancer patients because we've already determined that the gentleman, the patient, was a high-risk patient. When we click on clinical trials, we'll then have a list of potential clinical trials. Now, some of our sponsors are right here. And so let's just click on one clinical trial from them. Now, what's interesting here is this is what people don't recognize is if you go to a clinicaltrial.gov site, it's a very complicated site. And sometimes it's very difficult for people to read through it and understand it. What FIN and what the FIGHT tool allows is patient summaries that we've written and worked with our sponsors to create. And they allow you to get a nice summary or background of the clinical trial, who may participate, who's eligible for the clinical trial. And instead of you having to run around and look for the links to get information, we can give you a link direct to the clinical trial for more information, contacts, if you want to look for clinical trials on your site, but also there are also links that allow you to go straight to a registration portal. And so you can start and inserting your information about who you are and your interest in clinical trials. So that's why we're very excited about this tool, because this tool will help the patient sit down with the doctor, his or her doctor, the caregiver, as well as the family member, can sit down with the patient's doctor and have an intelligent conversation and walk away feeling more empowered. Instead of being reactive, now they're taking a position where they have a better control, a proactive stance in their care. Now you'll see why we're so excited about FinPath. But what I want to do is, now I'm going to hand this off to Dr. Blanc and let him talk about, educate you or give you more information about prostate cancer. Dr. Blanc?
I would like to start by saying it's an honor to be here. I come from a family that has been, I would say, victims of prostate cancer for generations. My grandfather passed away from prostate cancer. My father passed away from prostate cancer. And this has kind of fueled a fire in me to educate and work and do research and see patients with prostate cancer. So I practice in Florida, and it's always a pleasure to speak to patients about prostate cancer. So let me open the presentation. I'm trying to share my screen. 1 second. Okay, can everybody see my screen?
Not yet.
Okay. Oh, is it visible now? Can you see my screen? Okay. So I'm going to start by saying that today we're going to be talking about an overview of the disease, give some definitions that you're going to hear your doctor talk about. He's going to mention a lot of words and things that may seem foreign to you. So I'm going to help clarify these things. And then I'm going to go on to talk about treatment options. And then I would like to educate everyone about the roles of androgens in prostate cancer. What are androgens and what is its implications on prostate cancer? So there was a study done which has shown that men typically deal with prostate cancer in the following ways. They either take a proactive approach, the patient wants to fight this, wants to win the fight, it's compliant with their doctor and does everything their doctor says. There's another group of patients who just sit in front of the doctor with a poker face and just want to know statistics and numbers and deal with it without emotions. There's the third category of men who are confused and are just there telling the doctor, I'll do whatever you want, just get me out of this. And then there's the other, that's the unfortunate group of patients who feel hopeless. They show up to see their doctor hopeless. They think it's a death sentence and they don't work with their doctor because they gave up before they even started the fight. Nonetheless, we treat all these patients and we try to make the last group that we saw, the hopeless part, we try to bring them a more proactive and fighters of the disease. Every patient, every cancer patient, this is not only prostate cancer patient, but every patient will show up. They're extremely confused. They were just given a diagnosis. They were just told they have cancer. They don't know anything about cancer. They've heard from their neighbor, from their friend about cancer. They have mixed up emotions and thoughts in their mind. And this is where the tool that Dr. Crawford spoke about can help kind of clarify in a scientific way the stages in what we're dealing with when it comes to prostate cancer. Another thing is the patients don't know what the future holds. Okay, I have prostate cancer. What now? What is it now? And then the third thing is they have an underappreciation of what it means to be stage 4, which is metastatic disease. Every prostate cancer, before it becomes metastatic, is curable. And these patients need to be educated on what it means to become metastatic and why is it important to delay or even prevent that phase of the disease from happening. 1 in 9 men will have prostate cancer. It is actually the most frequent cancer we see. And 1 in 41 men will die of prostate cancer. So are there. And I'm pretty sure that a lot of us know someone who knows someone or even someone who has prostate cancer. So it's not a disease that we don't see often. This is statistics of all incomers. In African Americans, you see a lot more prostate cancer and it's much more aggressive and it presents with later stages of the disease because we need more education, and this is what we're trying to do today. So, how does it start? You go to your doctor, he does a prostate exam, he feels the prostate, he says, I feel something suspicious, tells you to get a biopsy, you go get a biopsy, and it shows up to be a prostate cancer. The other thing that can happen, go for a regular checkup, blood work at your primary care physician's office. He tells you that the PSA, prostate-specific antigen, basically, the definition is in the word, prostate-specific, no other organ secretes it. He tells you it's out of range. It's not in the normal range. You have to go see a urologist. You go see the urologist, he does a biopsy and tells you have prostate cancer. When the prostate cancer is localized, you can cut it out with surgery, we can give radiation, and we can explore other options. So the highest chance of cure you're going to get is when you catch the disease early, which is why we need to be very aggressive in how we need to ask our doctor every time we see him, do I need to get a prostate check? So our biggest chance of cure is with localized prostate cancer. Eventually, some patients who we treated locally with hopes of curing them have something called a biochemical occurrence, or PSA failure. Means that the PSA, which we talked about earlier, starts rising nice and slow, or maybe super fast. And this is when we know that the prostate cancer is back. This ways of treating it, but it eventually evolves into, and I'm going to focus only on the top circle, into something we call metastatic castration sensitive prostate cancer. I like to call it more so metastatic hormone sensitive prostate cancer, which means that the prostate cancer has spread to other parts of the body, which we're going to talk about. It's incurable cases, and it's feeding off of hormone, which is testosterone. Testosterone is an androgen. And you can think about a prostate cancer cell as a hungry animal which feeds on testosterone. This phase lasts for some time, and then it evolves into something called metastatic castration resistant prostate cancer, meaning that the cancer does not need to eat testosterone anymore, and it has become resistant to it. And this is the part of the disease where we have to get chemotherapy as opposed to easier, less side effect treatments. So, like I said, metastasis is when the cancer spreads from one place of the body to the next. It can spread the bones, lymph nodes, liver, lung, brain, you name it, it goes. It's basically the cancer is not in your prostate anymore. The cancer is just circulating all over your body. And when you hear the doctor say metastasis, this is what you need to be aware of. This is where a drug like Erleada comes through. Erleada is a pill which your cancer doctor will prescribe, which we use to treat metastatic prostate cancer. So Erleada will work here, here, and will work here. So once the cancer has spread, we can use Erleada for any of three. What's interesting is if we catch the disease at this phase where it is still sensitive to castration or hormones, Erleada can give us years more to live, and I will expand on that. So, if Erleada, if your cancer is still eating testosterone, to fight it is to starve it, right? We starve it. We give an injection. This injection will basically shut down testosterone production. And then we're going to combine it with Erleada. Erleada will do is that it will reduce the risk of death by 33%. So if you have 1,000 men, which was what they had in the study, and let's say 33% of them were going to die within the first year, Erleada came up and saved those 33 men. What's also extremely important is that, like I said, the cancer is spreading, it's nesting in different parts of your body. To slow it down as much as we can. How do we do that? The risk of progression, meaning we slow the cancer down. And slowed the cancer from progressing in 52%, by 50%, which is credible. I think we're lucky to live at a time where we have drugs like this compared to in the past where these numbers were nowhere close. Remember when I talked about this cancer that has become resistant to testosterone? It has mutated into a different beast and it's just eating whatever it can, and it doesn't care whether you deprive it of testosterone or not. And this is when we have to use chemotherapy. Well, back to these 1,000 men. If, let's say, without Erleada, these men had, out of the 1,600 need chemotherapy at year 2, Erleada took away that risk. So it delayed the time to which we will have to get chemotherapy. So the more time you're on Erleada, the more you're pushing the need for chemotherapy away. So if the cancer has decided to become resistant to testosterone, it doesn't eat testosterone anymore. And it decided to just hang out in the prostate for a little bit. It hasn't become metastatic yet. This is an area of interest for doctors because we know that normal therapy to deprive the body of testosterone is not working anymore. So we're just counting minutes and time until it starts spreading. It's only a matter of time. What Erleada does is that it stops it from spreading for an additional 2 years. Before that, it was 16 months, about a year and a half. Now, it's stopping it for another 2 years on top of a year and a half. So the time till you get your metastasis is 40 months with Erleada versus 16 months without Erleada. And the overall survival, I can't speak to it because this study came out, I think, in 2015 or 16, and the patients are still alive to this date. Like any other drug, this drug has side effects. It can, to which you need to speak to your doctor. None of them is an absolute contraindication, but you need to know that if you have seizures, if you have heart disease, if you're frail, be careful with these medications. Probably going to feel very tired. For that, we're depriving the body of testosterone, and testosterone energy. You may or may not experience a mild rash. I've seen it. It usually resolves on its own. And if it doesn't, tell your doctor. He'll make it go away. Joint pain, elevated blood pressure, a lot of things. But I would say, from a doctor perspective, it's a drug that I don't worry much about the side effects. So what do androgens play? What role do they play? Well, androgens are male hormones, testosterone, as I said, and they are needed for us to be men. Okay. However, too much of a good thing not even. Sometimes the prostate decides to use that testosterone as food and become cancer. So we have several ways of fighting against that by starving the cancer. And this is where the word castration comes from. We use an injection which blocks testosterone. And then we use, sometimes we use, back in the old days, we used to actually remove the testicles because they secrete testosterone. That's kind of an abandoned practice nowadays. And then, so there's two ways of doing this. You either stop the body from secreting testosterone, right? The other way of doing it is tape the prostate cancer so it can't eat. And this is what Erleada does. Erleada does not lower your testosterone. Erleada goes to the prostate cancer, which is eating your testosterone, and puts a lid on it so that it can't consume any more testosterone. Combine that with stopping testosterone. We can't stop anything 100%, right? Combined with decreasing testosterone of low level, you're basically creating a desert environment for the prostate cancer. And this is why these patients live longer. Before you take Erleada, of course, your doctor is going to ask you all these questions. Do you have high blood pressure? Do you have diabetes? Do you have cholesterol? Do you have seizures? All of these things. And after a discussion with your doctor, you're going to see that the efficacy outweighs potential side effects by a lot. You also need to tell your doctor about the medication you take because you don't want to take medication that interferes with the absorption of Erleada. How do you take Erleada? Once a day, without food. If you have to take your morning dose, take it at noon. Take it in the afternoon. Don't double up on a dose just because you missed a dose. How do you store Erleada? Somewhere safe, and it's fine. Protected from light. Basically, you can't take Erleada with you to the beach or put it in the freezer. Follow instructions. That's what we beg every patient to do. Please follow instructions. Always call your doctor for medical side effects. You need to take care of yourself, and it's a shared responsibility between me as a doctor and you as a patient. You need to help me help you by being accountable for what you feel. I can't follow you home and look at your chest and see that if you have a rash or not, right? You have to let me know, and I'll take it from there. So, Erleada was the first FDA-approved prescription medication for non-metastatic castration-resistant prostate cancer. And it's now available to treat patients who have sensitivity to castration. Erleada helps patients live longer. It lowers testosterone by blocking prostate cancers from eating it. Common side effects, like I said, feeling tired, rash, decreased appetite, weight loss. This last statement is very important. It is vital that men become active participants in their treatment and that they discuss with their doctor and healthcare team which treatment options for them. You have to ask questions. You have to educate yourself, because the only way you can fight this battle, I'll remember G.I. Joe, knowledge is half the battle. some questions that I would ask my doctor. Can you tell me why the cancer has advanced? Can you tell me if Erlita worked for me? Can you tell me if it helped slow down my disease? Effect? Is there financial aid, assistance in case I have expensive copays? Company that makes Erlita help me? And the answer is yes, they do. They can give you the drug for 0 a month. One thing that's very dangerous is what you find on the internet: misinformation. I recommend it. Organizations: cancer.org, cancer.gov, prostate cancer condition, prostate conditions, prostatehealthed.org, and the other institutions that I posted on here, which are all respected, follow scientific evidence, and have doctors the information that's given to the patients. The worst thing you can do to your doctor is come to him claims and arguments that you read on a blog from someone in Wisconsin whose neighbor had prostate cancer. I would like to thank all of you for this wonderful opportunity. And if you have any questions, please let me know.
Dr. Bond, Simon, thank you very much. That was very informative. And I want to remind everyone we're still taking in questions. And there was one question that came up that I wanted to run by you. Now, the question that the person had was, does Erlita cause sexual problems?
That is a very valid question, and I'll answer very, how should I say it, very, very candidly. Erlita, I would say, here's what it is. If you're on Erlita, you're also getting testosterone deprivation therapy. Testosterone deprivation therapy will stop you from making testosterone. If you do not have testosterone, you will experience sexual side effects, and you will experience sexual side effects. Erlita comes in, also affects testosterone. So what that means is that there is a very high likelihood that you will have sexual dysfunction because of the overall treatment of prostate cancer.
Okay, thank you. Another question that a listener had, they needed help understanding the difference between local and regional and non-metastatic, those terms that you were using.
That is a question. So the whole regional prostate cancer thing came about not too long ago. And it actually came about when we have improved our strategies in how we image prostate cancer. We have better ways to visualize prostate cancer. So what that tells me is that patients who have prostate cancer have localized disease, which is sitting inside of the prostate gland. Is when the disease spreads inside of the pelvis, but not to any major organs. The most affected parts would be the fat surrounding the prostate gland and the lymph nodes that are in proximity of the prostate glands. Lymph nodes are usually there to protect us from infections. the cancer unfortunately jumps to them as a first vessel to get to the body. So they're our first line of defense. And when the prostate cancer jumps to those, this is called regional disease. It is treated a little differently than localized, but more aggressively because it is the first, the last step before we go metastatic. Non-metastatic prostate cancer, both regional and localized.
Okay. Okay, good. Thank you. Thank you. Another question that came up was, you said that there was increasing fractures, and why is that?
I'm sorry, increasing what?
You're one of the side effects that are associated with.
Yes, increasing fractures. Yes. So it's very similar to when women go into menopause. When you lose the hormone, which is testosterone, testosterone helps men. The functions of testosterone. This is what they teach us in school, right? It gives you virility, a beard like mine. It gives you manly features. It gives you muscle, and it gives you bone density. This is why men are bigger than women because of testosterone. When you stop testosterone, you're going to get the opposite side effects, right? You're going to start losing hair. You're going to lose muscle. You're going to lose bone density. You're going to lose sexual strength and libido. And you're going to feel more tired than the usual.
Okay. So that means that in addition to your bones are very important. So it's really important to take care of your bones and take the appropriate supplements.
Yes, and we usually, as doctors, we are very preventative in that. We do bone scans to see how thin is the bone and if we need to add an agent to strengthen the bone. We also give bone fortifying agents that we know help increase survival from prostate cancer.
Okay. Okay. And then there was something else that came up just recently from the CDC, and this fits very well with the next question. But the CDC just again made an important, it was an important publication because it stated that early detection is very important. So that's what we heard you say. The earlier the cancer is detected, the longer you live. And 5-year survival is 100% if it's detected or early and it's localized to the prostate. But this report was interesting because I think it was the first time I read a report that talked about 10-year survival. And even people that are 10 years out, if they have identified the cancer earlier on, they were living in the high 90%.
Rule of thumb with cancer: the earlier you catch it, the better. Okay? I'm on several committees to address prostate cancer in minorities. The biggest challenge we face is that we are, as minorities, too macho of a mentality and approach to prostate cancer that we don't want to talk about it. We don't want to go see a doctor for it. We don't want to accept the exam that is done to feel the prostate. So, in my mind, that quick, minimally invasive exam could save your life. And we have every scientific evidence that the earlier the better from every authority in the world. It just if you have a fire, if it's in one room, your chances of controlling it are much higher than having it in your entire house, are much higher than having it in your entire block, or much higher than having it across the state. So it's like everything in life. The smaller, the weaker, the better we can fight it.
Mhm. Oh, I mean,
I have a question here from one of our attendees, and he's asking if someone with high blood pressure and what I believe is AFib, atrial fibrillation, have zero chance of being on Erlida. Well, I would like to say to you, sir, that no, you can be on it, but you need to inform your doctor because he or she will take the necessary precautions so that these would not interfere with you getting Erlida.
okay, thank you. Thank you for answering that. And I think we could take one more question. And Erlita, why do you think, or shouldn't Erlita be given earlier if it has this effect on increasing the life 2 years?
Yes, that's a that's a great question, and I'll tell you why. As simple as that. And we're seeing that with vaccines, right? Theoretically, if you want to extrapolate, if this was, let's say, if this was 1975, I could use Erlida from the day I diagnosed prostate cancer. No one would ask me any questions. But as we learned as the years came by, is that you need to make sure that these drugs are studied and you have proof that these drugs work. You can't, unfortunately, Erlida right now, to my knowledge, does not have data in the very early stages of the disease. So what's going to happen in the future is that these studies are going to happen, but they're on thousands of patients and they take years to mature because, like you said, if we give it to a patient, if he's already metastatic and he's living 2 years plus the year and a half that he was living before, that's 3.5 years. So if you give it earlier, this patient might live for 7, 8 years. So we have to follow that patient to come up when we make a presentation like this and say 90% of our patients live 10 years. And to get to say 10 years, we have to put them on the drug for 10 years. And the drug came out in 2017 or 16.
And it's interesting too, because in that same report from the CDC, they had mentioned that men who had metastatic disease, a 5-year survival dropped to 30%, around 30%, under 30%, and then the 10-year survival was in the high teens. So now, if they had access to Erlita, you've already said it's like doubling your life expectancy. So this is what we're talking about being so excited about the field of the treatments that are available to us. And that's why it's very important for now this to not stop and be afraid. The patient now has to be able to identify what treatment pathway they need to follow. Because we're now looking at, with every year we move towards making prostate cancer almost like a chronic disease.
Absolutely. Absolutely.
So is any last words, advice you want to give our audience?
All I want to say is, like I said, prostate cancer is a very dear topic to me. I expect to have it because I have genetic disposition for it. So I'm very anxious to get new treatments also. And I encourage everyone to go for the screening starting age 40, especially in African American men, because in Black men, we have a higher incidence of prostate cancer. And unfortunately, it is the aggressive type of prostate cancer. So we need to be extra vigilant. And if we don't take care of ourselves, nobody's going to take care of us.
So I want you to say that one more time for me. Did you say what age should we start screening?
40.
All right. Okay. So,
That's
but,
4 years away for me.
oh, okay. But you are talking about it ahead of time.
Yes.
And so I
Yes.
take it that you're advising your family members and everybody about that.
Absolutely. Absolutely. My family, my patients, everyone.
Well, that's great. So again, Finn, the Finn family, um, would like to thank you for taking this evening with us to talk about prostate cancer and really give patients hope. Because at one time, it's like, well, I have metastatic disease. Now you're saying that there are treatments and therapies out there that can even help patients with metastatic disease.
Yes. What we hope is that we want patients with metastatic disease to live with the disease and not die from the disease.
Right.
We can't cure it, we can control it.
We can control it. We can control it. So I'd like to close on that note, and I'd like to thank the audience again for taking this time to allow us to share this hour with you. I'd like to take the time to thank all of our sponsors, because it's important for this information to get out. We're all moving away from less contact and we're moving virtually. But even if we're virtual, we can maintain connectivity. And remember, when it comes to prostate cancer, knowledge is your best defense against prostate cancer. So thank you all for attending.